5. Additional features. Speech, language and communication. Children with BBS may present with speech, language and communication differences, and development of these skills can be delayed. Though the literature is limited, it is documented that there is a wide range of communication abilities within the BBS population, varying from typical communication skills to more significant difficulties. BBS children may present with one or a variety of needs relating to their speech, language and communication, which are discussed below. Understanding of language. Receptive language skills describes how children learn to develop their understanding of words, phrases and sentences from verbal information, and alternative communication approaches such as gesture and written word. BBS children vary in the development of their receptive language skills. Some may find it difficult to follow information or instructions and develop their understanding of new words, and some may find it difficult to follow the narrative of a story or understand questions. Receptive language differences can mean that children find it difficult to engage in classroom tasks and access the curriculum. Use of language. Expressive language skills describes how children start to communicate their wants, needs, thoughts, feelings and reactions. BBS children vary in their expressive language skills. For some, they may need more time to use new words. They may find it difficult to tell a story, respond to questions, or use grammatical markers. Others may use alternative communication methods such as visuals, signing, or communication devices. Social communication. The social use of language describes how we start to understand how to successfully interact with others in various environments. This may be by showing interest in others, taking turns, and engaging in shared play activities, using facial expression, gesture, and non-spoken communication. BBS children can present with social communication differences as well as possible sensory needs. Some children are neurodivergent and require adults around them to adapt their communication and environment, to maximize their opportunities to thrive and best support their needs. Speech. Speech sound development describes how children acquire different speech sounds as they grow. Some BBS children may present with a speech delay, and some may not demonstrate early babble. Some BBS children may present with less typical speech patterns, such as a speech sound disorder or childhood apraxia of speech, CAS. Some children may present with differences in their resonance, prosody, rhythm and melody, and voice pitch. Treatment. A referral to a local speech and language therapy service should be made if there are concerns regarding a child's speech, language, or communication development. An assessment of the child's communication can then be completed, and specialist advice and treatment can be provided as early as possible. Hearing differences, if present, can contribute to a child's speech and language development. Children with fluctuating glue ear or a mild hearing loss can find it very difficult to acquire speech sounds in isolation and within language. Regular hearing tests will ensure that children are monitored regularly, and any active management can be implemented early. Useful links. Speech and Language UK, www.speechandlanguage.org.uk, 020 7843 2510. AFASIC, www.afasic.org.uk, 0300 666 9410. Quote, "Of course, the two things which inspire me the most to carry on with strength and determination are my children. Two bright, funny, intelligent, kind and loving young people who have enriched our lives and made us proud parents." End of quote. Parent. Seizures or epilepsy. The prevalence of seizures and epilepsy in BBS is reported as being much higher than previously recognized and significantly higher than in the general population. However, the reason behind this is still unclear. In the majority of cases, seizures stop before adulthood. Seizures can affect people in different ways, including a loss of awareness, unusual sensations, and jerking and shaking of the body. Seizures can occur when awake or asleep, and sometimes there are triggers such as tiredness. Patients or parents should seek urgent medical help if they suspect they or their child has had a seizure. A referral to a neurologist would be appropriate for investigations and tests. Signpost: Epilepsy Action, www.epilepsy.org.uk, 0808 800 5050. Epilepsy Society, www.epilepsysociety.org.uk, 01494 601 400. Neurological abnormalities. Ataxia is a term for a group of disorders that affect coordination, balance, and speech, and is reported in a significant number of individuals with BBS. Hypotonia, a condition marked by an abnormal increase in muscle tension and a reduced ability of a muscle to stretch, is also commonly reported, as is low muscle tone. Some limited brain MRI studies have shown that some patients with BBS have smaller, unusually formed hippocampi, and that there is a tendency towards decreased overall white matter. However, it is not clear if or how this affects neurocognition. A number of patients with BBS report difficulties with memory function. People with BBS may have an impaired sense of smell, anosmia, due to changes in the region of the brain responsible for processing smell, called the olfactory bulb. Hearing. Conductive hearing loss, almost always caused by glue ear, affects many children with BBS. This often resolves spontaneously or with treatment by adulthood. A minority of patients with BBS have sensory neural deafness. Treatment. Glue ear management, myringotomy tubes and/or hearing aids. Assessment. At diagnosis, audiogram, audiometry, tympanogram, and auditory evoked potentials. Follow-up, yearly examination, audiometry, and detect glue ear, acute and chronic otitis media, which can lead to conductive hearing loss. Digestive system. A survey undertaken by BBS UK indicates that gastrointestinal problems are a common issue in BBS, and this is backed up by anecdotal evidence from patients attending the BBS multidisciplinary clinics. Commonly reported symptoms include constipation, diarrhea, bloating and cramping, and further research is needed in this area. Individuals who are experiencing difficulty should consult their GP, who may wish to refer for investigations or dietetic support. Patients attending BBS clinics should discuss their symptoms with a member of their clinical team. Hirschsprung's disease occurs more frequently in Bardet-Biedl syndrome than in the general population, but the incidence is unknown. The condition is present at birth, congenital, as a result of missing nerve cells in the muscles of the baby's colon. A newborn who has Hirschsprung's disease usually cannot have a bowel movement in the days after birth. In mild cases, the condition may not be detected until later in childhood or rarely as an adult, presenting as a swollen abdomen, poor appetite, and constipation that does not respond to any of the usual treatments. Orthopedic abnormalities. Examination and early identification of scoliosis, curvature of the spine, genu valga, knock knee, genu vara, bow leg, and pes planus, flat foot, will allow for early interventional treatment and may avoid unnecessary discomfort. Physiotherapy and orthotic referral should be considered. Early orthotic intervention and supportive footwear and/or insoles will ease discomfort and protect feet against further damage. Liver. Fibrocystic liver disease, problem with the biliary system, and fibrotic liver disease, scar tissue buildup, have been reported in a very small number of cases of BBS. Coexistent metabolic dysfunction-associated steatotic liver disease, MASLD, can evolve over many years, driven by obesity and type 2 diabetes. It can manifest within a spectrum of disease that ranges from simple fat accumulation that has few, if any, clinical consequences, to inflammation, metabolic-associated steatohepatitis, MASH, and in some cases scarring that can lead to liver cirrhosis. It is progressive in some, but not all, patients. Managing the condition relies on staging the severity of steatotic liver disease, SLD, and treating the conditions that predispose to it, namely reducing weight and optimizing blood sugar control in patients with diabetes. Liver assessment, measurement of plasma, ALT, AST, and GGT concentration, and liver ultrasonography. Cardiovascular. Hypertension, high blood pressure, is a common feature of Bardet-Biedl syndrome and often presents in childhood or early adulthood. It may occur as a result of other features contributing to metabolic syndrome in BBS, in particular obesity. It is imperative that hypertension is treated since it can contribute to renal deterioration and prematurely stiffening of blood vessels, predisposing to cardiovascular disease such as a stroke or heart attack. Both lifestyle modification and pharmacological intervention are encouraged. Congenital heart disease, present from birth, has been reported in a minority of BBS patients. Dextrocardia, heart points to the right instead of the left, and occasionally complete situs inversus, where organs are positioned opposite to normal position, have been reported, but these are rare. Cardio assessment, blood pressure monitoring, auscultation, ECG, and echocardiography. Joints. Many patients with BBS report pain in weight-bearing joints, probably because of osteoarthritis. However, a small proportion also have abnormally hypermobile or lax joints, the cause of which is unknown, but may be associated with hypotonia, decreased muscle tone. Dental. Some people with BBS have unusually short tooth roots, especially on the front lower teeth. Crowding of the teeth necessitating extraction is common. Many patients have a high arched palate and occasionally enamel dysplasia. Developmental defect of the enamel is evident. These abnormalities can increase susceptibility to tooth decay and loss, and regular dental supervision is advisable. Respiratory system. Asthma commonly affects individuals with BBS, with prevalence reported at around 21%. Recurrent chest infections are also more common in people with BBS, especially in childhood. This may be associated with dysfunction of the respiratory cilia which line the airwaves. Obstructive sleep apnea, OSA, is common and related to excess weight, particularly around the neck. This may be compounded by low muscle tone and soft palate discoordination. All patients should be questioned about their quality of sleep and the presence of daytime somnolence, excess sleepiness. Carers and parents should be asked about snoring and episodes of stopping breathing while sleeping. Evidence suggesting obstructive sleep apnea should lead to referral for sleep studies and lung function assessments. It is important to treat obstructive sleep apnea as it is a risk factor for medical problems later in life, especially cardiovascular diseases such as heart attacks and strokes. Many BBS patients report that treatment, for example nocturnal CPAP devices, results in major benefits such as increased activity, weight loss, and lower blood pressure. If there are concerns about respiratory difficulties, we recommend a referral to a respiratory specialist who can decide on the most appropriate next steps.